Hello, everyone. Good morning, good evening, good afternoon. Welcome to this oral presentation by Nicholas Bartisevic from the Pontificia Universidad Católica de Chile. Uh, this presentation is titled Factor Structure and Diagnostic Properties of a Digital Version of the Audit compared to the DSM 5 and timeline follow back in current drinkers in Chilean primary care. Um, Welcome, Nicholas, and welcome to all
Thank
the
you.
attendees. Some of you know the housekeeping rules by now, or all of the features of this platform, but I'll just quickly remind all of you there's chats to your right. You can type in your comments there during the presentation. There's Q&A next to chats. You can ask your questions there, and they will be addressed in the last 5 minutes of this session. Um, Nicholas will speak first for 15 minutes, and then we will have the discussion on the questions. Over to you, Nicholas.
Thank you very much, Miriam. I'm gonna share my screen now. So hopefully you're seeing my slides now. Okay, I'm Nicolas Bartisic. Thank you very much for this moment to share with you our results. A little bit of background and rationale of our study. The audit is a very well-known instrument, very studied in several countries. So why we are undertaking a new validation study in Chile? Well, because we need efficient detection of alcohol problems. Chile has a wide national program on SBIRT, screening and brief intervention and referral to treatment. So you need to be accurate and effective and in a short time. So our focus was trying to identify better, shorter screeners that eventually could be embedded in other medical checkouts in primary care, let's say in the waiting rooms, and do that in a digital format, because that's the way things go now. We are starting from a previous version already validated in Chile. So we had a linguistic validation by Alvarado and collaborators. They demonstrated good retest reliability for the audit in our population and good diagnostic properties, although they studied an enriched sample, not a typical primary care client sample. And that version was on paper, so we are unapplied by an interview. So now we are moving to a digital self-applied version. One concern we had is that in practice, we've observed difficulties with the conversion to standard drinks. This is not something that all people can do easily. So we try to facilitate that in our digital version too. So we ran a cross-sectional study with 369 participants from 2 primary care centers, all of them 18 years old plus, and that had used alcohol at least 6 times during the last year. We stratified our samples, so we had the same number of women and men, and also by age stratum. So we had like a balanced sample. All participants responded the digital version in a tablet by themselves. They didn't receive any help to do that. And we adapted some of the previous content. So we added the time frame to each question to remind the participant they were being asked about last 12 months. The item 2 was facilitated through pictures of the actual drinks in the display. So you didn't need to do the conversion yourself. And the item 3 was changed from 6 or more drinks to 5 or more drinks to better represent the standard drinks, the content on the standard drink in Chile. We compared this with the Telesage structured clinical interview for DSM 5 and the standard timeline follow back, both administered by trained psychologists with clinical experience in a separate room. They didn't also had access to the results of the digital audit. And we ran 2 main analyses. First, to check the construct validity, a nonlinear confirmatory factorial analysis. Nonlinear because we needed to account for non-normality, floor effects, and all that AUDIT has, and receiver operating characteristic curves. Those were the two main analyses. I'm going to show you now our results. First of all, I want to describe a little bit more our population. This was not an easy task because binge drinking is the way people drink in Chile and probably in Latin America. So we couldn't use that like total daily consumption. That kind of measurements didn't capture the hazardous patterns of use. So we built these categories of binge drinking. Binge drinking is 3 or 4 more standard drinks in one occasion for women, men, and intense drinking, the double, 6 or 8 or more drinks, women, men in one occasion. And then you have people who were regular bingers, who had at least 6 or more occasions of binging in the last year. So any binging was quite frequent. Around 80% of our population binge drink at least once in the last year, but regular binging was 30% of the population. And we are going to use this category for the subsequent analysis I'm going to show you. Regarding alcohol use disorder, well, the DSM V has a lower threshold. So if you just ask for any alcohol use disorder, 30% of our population had any. This is a non-selected primary care clients population. But if you stick to moderate or severe categories, then you have 10% of the population with these disorders, 16% in men, 8 to 9% in women. This is more like a comparable picture of what you can find in previous literature using DSM 4 or even 3. So our population has 30% of them had some pattern of misuse, and around 10% had alcohol use disorder. Okay, so first we ran the confirmatory factorial analysis to check the construct validity. You probably all of you know the AUDIT. This is just a very quick reminder. You can consider the AUDIT as a one factor, and this is what we usually do when we just sum up all the items and end up with a total score. However, there is a lot of literature showing that in primary care and other settings, AUDIT behaves as a two-factor structure, a consumption factor, items 1, 2, and 3, and then the remainder items in a alcohol-related consequence. And you also have a three-factor structure, which was the original idea of the AUDIT developers, which includes like dependency symptoms and consequence. There are other structures as well, but we just checked these 3. And what we found is that only the 2 and the 3-factor structures had a good overall fit. So we discard the 1-factor model. These are the items loadings for the 2 and the 3 factors. As you can see, all the items load very high and significant, which leads to very interpretable structures. However, we found 2 localized areas of strain. Even though the global fit was good, morning drinking was over-correlated with the consumption factors in both models. And concern of others about your drinking was under-correlated to the consumption factors. I think the consumption factor. I think this is more of a concern because item 10 is a very important item in the AUDIT, as shown by previous literature. Morning drinking is rarely endorsed in primary care, but concern is an important item. So this is a flaw of our 2 and 3 factors structures. We finally choose the 2-factor structure because we didn't think that the 3-factor added anything new. And something very important that we found, and this is different from a previous literature, is that the correlation between the consumption factor and the consequences, the negative consequences, was 0.35, which is low. Literature usually reports correlations among 0.6, 0.8. We think this speaks of a good discriminant validity of our instrument. So audit is really differentiating consumption from consequences. Two different factors. You can't just sum them up. You are kind of losing some information if you do that. So to show you that's the case, let's see what happened with the diagnostic performance of these different measurements. We're gonna see the audit total, the modified FAST, which is binge, loss, role failure, blackouts and concerns, and we're gonna see the audit C, which is only the 3 consumption items. The audit compared to DSM 5 performed very well. So this is what's usually found in the literature too. However, audit C didn't perform as well. And this is consistent with this 2-factor structure. However, the FAST somehow perform exactly the same as the audit. There you have the areas under the curve. Audit is 0.85, which is fairly good. However, audit C was significantly lesser, 0.72. It's not bad, but it's not as good as the audit total or the FAST. Same thing if you, this is regular binging, not alcohol use disorder. The audit performs not as good as previously. The area under the curve is only 0.75, which is fair, but not excellent. And there were no difference between the audit C, the total audit, or the MFAST, as shown in the table underneath. So what does this suggest? How do we proceed? Do we use the audit C? Do we stick with the total audit? And what's been sometimes recommended in the literature is to use sequential use of these scores. So I'm going to show you what happens when you just use the audit. These are thresholds for both alcohol use disorders and binging, regular binging. So as you can see, women had lower thresholds than men. That was to expect. However, the audit seems not to differentiate among those. You have the same best score for regular bingers or for alcohol use disorders, around 7 for men and 3 for women. However, if you go to the FAST, you have different scores. So these short scores are somehow capturing better the factorial, the underneath factorial structure. The same with the audit C. You have 3 as a best cutting point for regular binging. However, you need to go higher to get to detect alcohol use disorders with the audit C. So if you do this sequential testing, here in black, you have the performance of the total score. But if you go with the audit C in blue, and then only the positive, those who score positive go to the audit, you have the same performance. The same with the FAST. So it looks like sequential testing is a good idea. It saves time, and you don't lose performance, diagnostic performance. So to wrap up, we think that a 2-factor structure best captures what the audit is doing in our population, and you have a consumption factor and an alcohol-related consequences factor. In our setting, the instrument, the audit presented high discriminant validity. You really could separate those population, at least in the factorial analysis, and also some of that was shown in our diagnostic performance analysis. The performance of the total score was excellent for alcohol use disorders, but fair for hazardous use, and probably is not a good score, the total, for differentiating among both. And this is, we think, the spirit of the audit, being able to differentiate people who are really having a dependency alcohol use disorder from those who have a hazardous or harmful use. The MFAST outperformed the Audit C for the detection of alcohol use disorders. So if you were to choose one brief screener, maybe the FAST is better. However, we agree with a more common recommendation that you can use a shorter screener, for example, the Audit C, as a first step, and then use all the remaining items to identify, qualify all the other problems in that population that already scored positive in the Audit C. We think that more work is needed to identify patients with different degrees of alcohol problems, the audit zones that are in the audit manual, implementation manual, but usually have not, there's little literature showing how to use the audit to do that. And we think that probably using the total score is not the best way to go, because you're mixing up things that are different. Maybe using these underlying dimensions can help you identify those different populations, people who has hazardous or harmful use, and people who really need a referral or some kind of treatment because they have already an alcohol use disorder. Okay, I think that's about it. I'm not sure if I'm good on time.
Yes, thank you, Nicholas. You're right on time. If anyone has any questions, you can add them in the Q&A section. But until then, Nicholas, if you could just describe to us what are the plans, the next steps further from this study, if you have it.
So, well, our plan is to implement a digital brief intervention, automatized brief intervention, so people can go to the primary care center, have the screener in a tablet, and if they screen positive, go straight to a digitalized brief intervention. Unfortunately, getting physicians, nurses, or any professional to do this in primary care is difficult, as we already know. So we are moving to digital. And we think it's very important to embed these questions in a more medical general questionnaire, asking about sleep, food, exercise, all together, because otherwise you are kind of separating alcohol from the medical setting, and that's a bad idea. That's not what we want to do in primary care. So our next steps are developing a digitalized brief intervention that continues this screening process.
All right, excellent. Thank you for that, Nicholas. And if there are any other questions from the participants at this stage, we still have a minute. All right.
Good. Thank you very much, Miriam.
There is one question from Martha Leticia. Will you publish your work? I think it's a question on will you publish your work?
Hopefully, yes, I'm working on that, but it takes time. Hopefully, I will do that soon. Any advice on where to publish these results? I don't know if the scope is very local because it's been done in Chile, or there are topics that are more of a general interest. So, but I think we need to publish it.
Yes, it is very relevant for us as well, because we do use a lot of the audit C and the audit in our work here in Goa as well. So I think definitely relevant to other low and middle income settings.
Okay, so I'll try to go not local as suggested by Peter. Thank you very much.
All right. Thank you, everyone, for joining us, for participating. Thank you, Nicholas, for your presentation. We will now end this session, and you can move back to the program and head to other oral presentations. Thank you.
Bye
Bye-bye.
bye.